Okay, so I want to talk a little bit about hypoxia and the possible causes for hypoxia. Now, oxygen, as you remember, is diffuses into the capillaries that surround the alveoli. So several things are required for the oxygen to move from the air outside into the alveoli and then into the bloodstream. So hypoxia is something that is caused by something that blocks the oxygen at any one of these levels. Okay, so the first thing that can happen is you can have decreased fraction of inspired oxygen. So there's just not as much oxygen in the air the person is breathing. So that's called, that would be decreased FiO2, or fraction of inspired oxygen. So fraction of inspired oxygen. So usually that is 19 to 21%, depending on the level of moisture in the air. So how can this decrease? Well, you can be suffocating, and you're in a small space, or you've got a small space around your airway, like a bag over your head, and you are slowly using up all the oxygen in that small enclosed space, and that causes suffocation. As your body uses up oxygen, the FiO2 is going to drop. The other possibility is high altitude. Maybe if you're riding in an airplane and there's a loss of cabin pressure, you're going to, at those higher altitudes, the amount of oxygen in the air is much lower, and that's going to decrease the amount of oxygen that you can be breathing in. So number one is decreased fraction of inspired oxygen. Number two would be hypoventilation. You're not breathing enough to bring air in. Now, if you remember our earlier slides when we talked about hypoventilation, the first thing that's going to happen with hypoventilation, because it diffuses much faster, is that, actually CO2 levels are going to increase in the bloodstream, right? Because the CO2 is going to build up very quickly in the alveolar space because of its rapid diffusion, and then only after a few minutes later is the oxygen level going to drop. Okay, so that's the second thing that could happen. The third thing that could happen is that there is just decreased blood flow past the alveoli, and if you decrease blood flow past the alveoli, there is less blood to exchange oxygen at the alveolar level. So you could have decreased cardiac output. And this usually has to be fairly extreme because there is such a large reserve in the lungs. So you'd really have to get it, your cardiac output down to sort of about half normal. Normal in a male, I believe it's 2.2 liters to 4 or so. And I'd have to look the numbers up to be precise. It's been a while since I've worked with Swan catheters, but to have a significant drop in oxygen levels because of poor perfusion through the lungs, you would really have to have a cardiac output drop to like 1.5 liters per minute or less. And obviously you're going to have many issues with systemic hypoperfusion as well with that kind of drop in cardiac output. Now, another possibility is we could have impairment of this membrane. So if we have thickening of the alveolar capillary membrane, remember oxygen is diffusing down its concentration gradient by simple diffusion. And this works very well because usually the membrane is 0.2 nanometers thick. Now, if you increase the thickness of this membrane, you are going to decrease the diffusion of oxygen, and you're going to require a higher gradient. So the oxygen concentration here in the bloodstream is going to be much, much lower than it is because it's crossing a thicker membrane. So number 4 here would be, here, let me make that green. Number 4 would be impaired diffusion, and this happens with some diseases that cause pulmonary fibrosis. So fibrotic membrane. And we have ways of measuring diffusion. There is a test called DLCO, which is the diffusion of carbon monoxide, and we actually use small amounts of carbon monoxide to test the ability of the gas to diffuse across this capillary membrane, and it is a good estimate of our ability to for oxygen to diffuse across that membrane. So if someone has had a complete set of pulmonary function tests, one of the tests that they will have is a test of their DLCO, which is a measure of diffusion, and if there's significant impairments in that diffusion, it suggests that there is fibrosis of the membrane, and that in itself can be a cause of hypoxia. Okay, and then the next would be a right to left shunt. Now, a right to left shunt suggests that oxygen is moving from the right side of the heart to the left side of the heart without getting oxygen, without passing by oxygenated alveoli. Well, here's a rough picture of our heart. So remember, on the right side of the heart, which has unoxygenated blood, we have going through the pulmonary arteries and into the lungs, right? And on the left side of the heart, we have oxygenated blood, and that leaves the left ventricle through the aorta into the systemic circulation. Now, one type of shunt may involve a anatomical defect that causes the unoxygenated blood to mix with the oxygenated blood. So it may be a PFO, otherwise known as an atrial septal defect. It could be a ventricular septal defect, or VSD. And this will cause it to, this is a anatomic shunt that causes the blood from the left side of the heart, the right side of the heart, to mix with the left side of the heart. Now, we can also have a physiologic shunt, and this is the other name for a physiologic shunt is called a ventilation to perfusion mismatch, or VQ mismatch, and we talked about this in another slide. VQ mismatch. And this just means that blood, because of some kind of disease, is passing unoxygenated alveoli. So, in the most typical cases, this alveoli is filled with fluid or pus from infection. So it could be filled with alveoli filled with pus, and it's still being perfused because of vasodilation from the inflammatory mediators, or the alveoli may be filled with water because of edema, because of CHF, and there's no vasodilation here. However, because of increased venous pressure, it's going to sort of stent the veins open, and it's going to cause perfusion of edematous alveoli. So this is called a VQ mismatch. It is sometimes called a physiologic shunt, and it just means that the that we are perfusing a number of unoxygenated alveoli, so the blood is returning to the heart unoxygenated from parts of the lung. Now all of these things can cause decreased oxygen levels, and particularly arterial oxygen levels. And we will note them on an arterial blood gas. Okay, so that is a brief introduction to hypoxia. Now I do want to make the point that in most acute situations, acute hypoxia is most commonly caused by a VQ mismatch. I would say if you have a newborn baby, sometimes we will have an anatomic shunt. There are some disease conditions that can cause chronic hypoxia that cause impaired diffusion because of fibrosis of the membrane, and that hypoxia usually will have a mixed picture. Hypoventilation is sometimes the cause in chronic conditions like COPD. So really all of these causes of hypoxia can occur in chronic conditions, but the most common cause of acute hypoxia is typically a VQ mismatch that is caused either by pulmonary edema or infection. Okay, please let me know if you have any questions, and please take a moment to rate this by giving it a thumbs up or a thumbs down. And please, if you do give it a thumbs down, tell me why in a comment. Thank you very much.